My name is Zaytun, and I'm the moderator today. I am a GP and a Macmillan GP in Southwest London. We are privileged today to have Dr. Shairoz Merchant, a consultant medical oncologist at London Northwest Healthcare NHS Trust and Imperial Healthcare. She has completed a medical training at King's College London and her oncology training at Imperial College Healthcare NHS Trust. Having completed a PhD in developing new imaging techniques in breast cancer, her main focus is clinical work in breast and lung cancer. We also have Dr. Maureen Huda, who is assisting me in moderating the questions. She is a trainee GPSTI at Frimley Park and has had previous oncology experience as a junior clinical fellow at Mount Vernon Cancer Centre. So welcome to you all, and I will pass on to Shairoz.
Yalimath, everyone. I'm just going to share my screen, so just bear with me. So thank you to the Health Board for giving me the opportunity to talk about the future of cancer care. Cancer care, cancer brings out a lot of anxiety in people, but I can assure you that the future of cancer care is very optimistic and bright. And today I want to cover some of those aspects about the future of cancer care. So in today's talk, I'm going to give you a brief introduction about cancer. I'm going to talk about the NHS's ambition for cancer. They've got a 10-year plan. I'm going to talk about how we're trying to improve diagnosis in cancer, some of the new treatments that have come on the horizon, and how we can provide personalized care and support. As Professor Munir just mentioned, cancer is, cancer, just like any other illness, is becoming more and more personalized. So I'm going to talk a little bit about all of those things today. So cancer is not just one illness. Cancer develops when normal cells start to become abnormal. And this is because of some kind of genetic abnormality or because of some kind of external factor that makes a normal cell then become abnormal. This then causes the cancer cell to develop in a very abnormal way, and then that has the tendency to spread. So cancer is not just one illness. There are 200 different types of cancer. The statistic is quite sobering, actually. 1 in 2 people in the UK will get cancer in their lifetime. We know that the most common cancers currently, according to Cancer Research UK, are the 4 common types of breast cancer, lung cancer, prostate cancer, and bowel cancer. The most common cancer affecting women are breast cancer and men prostate cancer. However, there is good news. We know that 50% of people survive cancer for more than 10 years. This is because of earlier diagnosis of cancer and because treatments are getting better. And we can also do something to prevent our own risk from developing cancer. We know that about 4 in 10 cancers can be prevented. So on this slide, the bigger the circle, the bigger the risk factor. So we know that smoking is the biggest risk factor for cancer development. And being smoke-free is the best way that we can reduce the risk of cancer developing. After smoking, obesity is the biggest cause of cancer. And the NHS has just launched a campaign, which it had done before, but it is putting that more into prominence now with COVID, because we know that a better weight will not only improve your risk for cancer, but will also improve your risk of COVID. So the way that we can prevent cancer is by maintaining a healthy weight, eating lots of fruit and vegetable in our diet. We've had this slogan of 5 a day, but now we're looking at actually, can we eat an array of fruits and vegetables, different types, different colors, drink less alcohol, be sun smart. So, we know that exposure to sun can increase the risk of skin cancer, for example. We should be eating less processed and red meat and eat a diet that's high in fiber. And we know that this reduces the risk of developing bowel cancer. Also, in trying to maintain a healthy weight, being more active also lessens the risk of cancer. So there are a number of factors that we can help to try and reduce the risk of cancer developing. So the NHS's long-term plan looks at an array of things to improve cancer outcomes. The NHS long-term plan was published in 2019, and the aim of that was to improve cancer outcomes. What we want to do is try and improve diagnosis for patients. We know that approximately 50% of people are diagnosed with what are called stage 1 and stage 2 cancer. So this is when cancer is picked up at a really early stage, and therefore the chance of cure is much higher. The NHS's aim and the government's aim is that we should improve that to 75% of people being diagnosed at an early stage. Currently, we're only at about 50%. So it's really important that we diagnose patients early and therefore improve outcomes. The other vision of the NHS long-term plan is that we need to reduce inequality across the country. We know that some parts of the country do better than others in terms of diagnosis, and this could be related to social deprivation and other factors. So I'm just going to talk about each of these things in turn. I'm going to start by talking about prevention. The government is focusing particularly on smoking prevention because we know that, as I mentioned in my earlier slide, that smoking is the biggest risk factor for cancer. The other risk factor is obesity, and again, there's a campaign towards making the population a bit healthier. With respect to early diagnosis, screening is where we try and pick up cancer earlier than when symptoms develop. So you may be aware of programs such as breast cancer screening, cervical cancer screening, and bowel cancer screening. What we're trying to do is make those screening techniques much better, so improving the technology, but also looking at other cancers where the survival is not as great, for example, like bowel cancer and lung cancer. And there's really a drive to improve cancer screening in those particular subgroups. So for example, with lung cancer screening, the government is now targeting smokers, so that smokers or ex-smokers are now being targeted with a screening test. So they undergo a breath test. The breath test then determines whether they undergo a CT scan, and on that CT scan, cancer is picked up at an earlier stage. So we know that there is a potential to pick up cancer, particularly lung cancer, which presents in the later stages at a much earlier stage. There's also a drive towards what's called a 28-day faster diagnostic standard, where we can improve cancer diagnosis within 28 days of being referred by a GP. There are also these rapid diagnostic centers which are coming into place, where we can reduce the interface between GP and hospital, such that patients can get all their tests in one day, for example, and then get their results very quickly. So there is a drive now towards earlier diagnosis. Going on to the second bit, or the third bit rather, is access to new technology and drugs. We know that the machines that provide radiotherapy are being modernized and improved so that patients can have better access to technology. Also, the NHS has developed this Cancer Drugs Fund, which means that new cancer drugs are readily accessible to patients even before they're fully approved by NICE. So we know that there is a drive towards getting treatments earlier to patients so that patients can benefit from them earlier. There's also a drive towards personalized care and support, as Professor Munir discussed earlier. We're looking at a situation where one size does not fit all, and one patient's needs might be very different to another patient's needs. And not only can we provide personalized care during cancer treatment, but also after cancer treatment is completed. And then looking at service delivery, we know that we're trying to always improve the way that we're delivering care to our patients, particularly within COVID now. We're now looking at a situation where we're looking at innovative ways of providing our services to our patients. So this can include telephone consultations, for example, virtual consultations through video conferencing, also being able to provide treatment closer to home, for example, like providing treatment closer to home, such as chemotherapy closer to home. One of the things that we've set up at our hospital is a drive-through service for pharmacy. So for example, a patient will come in, have their blood tests, and then pick up their medication through the drive-through pharmacy. So we're just looking at better ways that we can improve service. And also we're looking at really collaboration between the different cancer, what I call alliances. So we're trying to look at collaboration between, let's say, London and the northwest of England to ensure that we provide equity of care across the whole of the UK. And as Professor Munir also mentioned, we need to look at research and data, because without research and without the data, we will not be able to improve outcomes. We know that particular areas of research are lacking. For example, we need to focus on cancers where there's poorer outcomes, for example, lung cancer, bowel cancer. So we need to focus on those particular areas. In addition, we need to look at how research can be really improved in the elderly. We know that the elderly are not being included into clinical trials, but we're now facing an aging population, and therefore it's important that we include elderly patients into our trials. A lot of them have complex medical problems, and this needs to be accounted for in the research that we're doing. I just want to now focus a little bit on the treatments that have changed the way that I practice in the last 10 years. And we're all familiar, I guess, in some way or the other, that cancer treatment is just chemotherapy and radiotherapy. But I want to focus on perhaps looking at other types of treatment that we may or may not have heard of, but which will come to the forefront in the very near future if you haven't heard of them now. So immunotherapy is a treatment where we activate the body's immune system to recognize and fight the cancer. Cancer is very unique in the way that it behaves. It tries to hide from our own immune system because it comes from normal cells. It has a tendency to not show itself to the immune system, because when the immune system recognizes that something is unusual in the body, it will try and fight it, for example, like a virus, for example. It knows that a virus is not normal for its body, so we'll try and fight it. Whereas our body's own immune system doesn't recognize that cancer is a problem. However, the immunotherapies now come to the forefront, where the body's immune system can be activated to recognize the cancer and therefore destroy the cancer. And this won the Nobel Prize in Medicine in 2018, and it was a great landmark in cancer medicine. And then you may have heard of radiotherapy. Now, radiotherapy is a treatment where we treat cancer with high energy X-rays. Radiotherapy previously only treated patients it involved treating both cancer, but also there were side effects of treating normal cells. And that causes damage to normal cells and therefore causes what we call side effects and toxicity to the body. These new radiotherapy techniques called gamma knife and cyber knife, these are very targeted treatments, and they can target the cancer without causing a lot of damage to surrounding tissue. And it's currently in use for things like brain cancer and other cancers where it's a small tumor that can be relatively easily targeted. So this machine here just looks like a robot, and therefore it can just beam high energy X-rays towards the actual tumor. So it's very clever, but there's more work that needs to be done, and I'll come on to that on my next slides. And then we talked about precision medicine in the opening talk, and again, it's changed the way that we manage certain cancers. So Professor Munir spoke about melanoma, where we identified a particular gene within melanoma skin cancer, and that showed a response to treatment within a few days of a patient. Similarly, we have targeted treatments in breast cancer, prostate cancer, lung cancer. We know that about 10% of lung cancers occur in non-smokers, and in those particular non-smokers, there is a high rate of what we call mutation or abnormality within the cancer, which we can then target with a targeted treatment. And those targeted treatments are not chemotherapy. They can be targeted treatments like a tablet, for example, something as simple as a tablet, which means that it can target the cancer in a more proactive way, not cause any problems to the side effects to the rest of the organs in the body, and therefore is tolerated much better and has a better outcome for the patient. And we already do this, as I mentioned, in breast cancer, lung cancer, melanoma, and prostate cancer. And then particularly within breast cancer, we've now got new tests that we can use to determine whether someone's cancer is at higher risk of coming back and whether they would benefit from chemotherapy. So this Oncotype DX test is a genomic test, and it looks at a group of genes within breast cancer, which looks at whether patients will need to have chemotherapy as part of their treatment and what the risk of their cancer is like to come back in the future. So again, this has changed the way that we practice breast cancer treatment, and we can give patients a more informed idea about how aggressive their cancer might be and what treatments they might benefit from, and also spare them chemotherapy, which potentially could be toxic to them. So these are the treatments that have currently shaped our practice in the last, I would say, about 10 years. When we look at future directions in cancer, as you can see from this BBC article from a year ago, there was a paper about artificial intelligence diagnosing lung cancer. And this is just one aspect of how artificial intelligence can help. And essentially in this trial, they looked at how a computer could diagnose lung cancer compared to a radiologist, who's an X-ray doctor who can pick up a cancer after years of training. And they train the computer according to a certain what's called an algorithm, and it can then diagnose a lung cancer to the same precision almost as a cancer doctor can, or a radiologist can. So there is potential for this in the future. This is not quite in practice yet, but certainly it would really improve the rate at which we diagnose certain cancers. And then I spoke a little bit about targeted radiotherapy. I talked about CyberKnife and Gamma Knife earlier. There's now a new type of radiotherapy called proton beam therapy. Currently within the UK, there are only 2 centres that do this. It's the Christie Centre in Manchester and at UCLH, University College London Hospital in London, which will start treatment from, I think, autumn of 2020. And again, I mentioned before that targeted radiotherapy to brain tumours can, to a certain extent, be very precise, but there's still a little bit of normal tissue, as you can see at the back of this tumor on the brain, that can get targeted by what's called the scatter of the radiation. With proton beam therapy, it's a different type of energy. It's not an X-ray beam. It's a different type of beam that comes from a proton, which is part of an atom, and that can go very precise radiotherapy without damaging the surrounding brain tissue. So that's the future direction, really, of radiotherapy. And then I spoke earlier about immunotherapy, and I spoke about how the immune system doesn't recognize a cancer cell unless we give it a boost to recognize that there is a cancer there. There are new types of immunotherapy called CAR T-cell immunotherapy, where a T-cell is a type of white cell which is part of the immune system. And as you can see in this diagram, there's a cancer cell. It knows how to hide very well from a T-cell or a normal cell that's part of our immune system in the body. And in this situation, what we do, or what the technology does, is that it removes the T cell from the body. It then provides it with a protein that recognizes the cancer, and then the CAR T cell now can then recognize and kill the cancer cell. So we're making even immunotherapy quite a precise treatment. This is a treatment that's not currently being used in the type of tumors that I treat, for example, like breast and lung cancer, but it is being used currently in blood cancers like lymphoma and leukemias. But I think there is a greater future for this for all types of cancer. And then there's something called liquid biopsy, and this is where we can determine if someone's cancer can be picked up from a simple blood test. We know that the way we currently diagnose blood tests, cancer really, is by looking at a scan, for example, and we take a sample of the tumor from the body, and then we can determine whether that's causing a problem, whether the cancer is present. Now, a liquid biopsy will pick up cancer either even before it develops, or it can pick up a resistance to treatment. For example, let's say in lung cancer, which I treat, if I've started someone on a particular treatment and I start to notice that perhaps the patient's not responding to treatment, I can then organize a blood test which picks up an abnormality, which can then we can then switch treatment to another targeted treatment. So we know that the blood test can help in also changing treatment as well. So not only can it help in picking up cancers before they develop, it can help change treatments, but also it can help with monitoring response to treatment as well. So I've just talked a little bit about certain aspects of treatment that can potentially be in the horizon in the future. So looking ahead, it's not just about the different types of treatment. As mentioned before, we need to look at more personalized care and support for our patients. And the NHS, in its 10-year plan, has also recommended that we look at how we can provide a more personalized care during treatment and even after patients have completed treatment. So we need to identify because everyone's different, everyone's needs are different, and therefore everyone has what's called a personalized care plan that will look at what physical support they might need, mental support, psychological support, whether they might need support even after they complete their treatment, both in terms of looking at the long-term side effects of treatment, and also how to get back to normality and how to get back to their normal life, getting back to work, and being able to counter the effects of treatment in the long term. And one of the things the NHS is very ambitious about is called the quality of life metric, where they will pick up a lot of data on how patients not only have in terms of their side effects during treatment, but also looking at the long-term quality of life after they've completed treatment. So this is a very ambitious project. It's the largest of its kind in the world, and it's looking at the quality of life metric. Personalized follow-up is where patients have completed treatment, and then following that, they will be given advice about how to look after themselves, both from a mental and a physical well-being, with advice and support both from Macmillan and other sites, from their GPs, as to how they could be able to get on with their life following cancer treatment. And again, they'll also be given advice about how they can look out for any return of the cancer, what to expect during follow-up with scans, for example. As I mentioned before, we don't have enough data for the elderly population. We need to be focusing on clinical trials, looking at the elderly population with complex needs. And innovation is key. We need to look at things like genomics, which gives us more information about the DNA of the tumor, looking at artificial intelligence as to how we could incorporate that into our practice, not replace us. And then looking at data, because we know that the NHS is a rich source of data. We have a huge data from all areas, from diagnosis to treatment, and now we're looking at future trends as well. So it's really important that we look at these aspects to provide us with the best possible data so that we can provide the best care for patients moving forward. And finally, I just wanted to mention that cancer care isn't just about one person, it's about a whole team of people looking after a patient, right from diagnosis, from the time that they see their GP to their oncologist to their surgeon. Geneticists may be involved because cancer can be related to genetics. And then there are various other allied health professionals like a specialist nurse, physiotherapist, pharmacist, and support can be provided not only in hospital, in the community, but also within our families, charitable bodies, our Jamaat Khanas. I've just put here at the bottom links to all the websites that I've used today, because I know there's a lot of information out there for cancer care. But I would highly recommend that these are the websites that I would refer to my patients to, and that I would recommend that you can have a further look at. In addition, I would just like to highlight that within our Jamaat, we have a cancer support group who are highly trained Macmillan professionals. So if anyone in the Jamaat feels that they need some more support, either because they're going through cancer or they have a family member who's going through cancer, we're available through the health board, either myself, my colleagues who are also present today, but also the cancer support team. And we're more than happy to provide you with any support you may need. So thank you very much for giving me the opportunity, and I welcome any questions. Thank you.
Thank you, Shairoz. That was an amazing talk. I would urge you to either put some messages on the chat or comments. I have one question, which is a very relevant question. Shairoz, due to COVID, there are limited access to GPs and there are delayed diagnoses of cancer. What would you advise the public or Jamaat regarding early detection? So before Shairoz answers that, I do want to sort of highlight as a GP that we do not have limited access. We are working flat out and we are here for you. So please contact us if you want to speak about your symptoms, your signs, anything you're worried about. But Shairoz, have you got any comments about that?
Yeah, absolutely. And just like Zaytun says, you know, COVID should not stop anyone seeking help. If you're worried about anything related to cancer, it's really important that you seek your advice of your GP, because as I mentioned before, the sooner things are diagnosed, the sooner treatment can start and therefore improve outcomes. So COVID really should not be a point of being worried about accessing healthcare, because even though we're worried about a potential surge, we still have to make sure that we're accessing our GPs. And as Zaytun said, and Zaytun's a GP, they are accessible.
So I can comment on telemedicine. So all of us are using telephone calls, virtual videos. And if you need to see your GP, then you can see them face to face, having spoken to them on the telephone. So do not shy away. Please do contact your GP. Do not sit at home worrying about your symptoms yourself. We are here for you to help you to make life a little bit easier for you. I have another question, Shairoz. You talked about artificial intelligence used in cancer therapy, and you shared the example of about lung cancer. What about in screening? What about in screening? Can you give us shed some light about how artificial intelligence is used in cancer screening?
We're trying to look at now, not artificial intelligence, but within breast cancer, for example, there is a drive towards improving screening with a different modality of screening. For example, the way that they do breast screening at the moment is looking at sort of 2D images. There's now a drive towards looking at 3D imaging of breast cancer, because we know that the breast is not just two-sided, we know that the breast is three-sided. So there is a drive now towards looking at 3D imaging in breast cancer. Again, in lung cancer, as I mentioned before, there is a drive towards looking at lung cancer screening through artificial intelligence. So developing computer algorithms that pick up lung cancer earlier than previously diagnosed. And hopefully preventing also biopsies, because we know that the only way of preventing, of picking up cancer is through getting a tissue biopsy. These algorithms that I mentioned before will be able to tell whether a spot on the lung definitely looks like cancer, for example, or not. So there's that drive towards using artificial intelligence, although it hasn't completely replaced it.
Thank you. So feel free to put messages on the chat or raise your hand and I will unmute you, or you can unmute yourself when you're asked to. So you talked about screening. Should patients be going to their screening because COVID-19 is there? Are screening programs open?
Yes, they are. They are. There was obviously there was a lull in breast cancer screening and other screening because of the problems with COVID, and a lot of centres have closed because of screening. But I can assure you that these are back on track. And please, if you have been offered screening, or you feel that perhaps you might have missed out on an appointment because of COVID, it's important to speak to your GP and find out what's happening. So I would urge everybody not to hold back because of COVID, because we know that screening picks up cancer earlier. And as far as I know, everything is back on track.
Absolutely, yeah.
So for example, even the bowel cancer screening, it's a simple stool test, which you can do at home. It comes as an envelope. You put your, obviously there's instructions as to how you provide that stool sample, but that's still taking place. So we know that bowel cancer screening from the comfort of your home is still taking place. I just wanted to highlight as well that when someone's stool test comes back as possibly abnormal, they're invited for screening with a what's called an endoscopy or a colonoscopy, or sigmoidoscopy, which is where they put a camera to detect whether there is a cancer. There has been, unfortunately, poor uptake of that. And recently there was a drive through NHS England to look at particular areas where uptake has been poor. For example, in West London, we know that uptake was poor. And so they were contacted via telephone to advise them of a time or a date that would suit them better. So that's how we're trying to really allow patients better access to screening treatments and screening investigations. So yes, there is a drive to ensure that everyone has access at a time that suits them, because obviously everyone's working, and with COVID, they might not be able to access the screening.
And interestingly enough, bowel screening is back on. So is cervical screening via general practice. So we have seen a drop in cervical smears. Please do contact your GP to get your smears done. We are seeing patients in practice with full PPE. Everything is safe and clean. We are happy to see you for your smears. So please do contact your GP for this. I would urge you to continue with the bowel screening through the post. And also the breast screening program is up and running again. So We are trying to catch up, so make sure you contact your GP if you're not aware of how to get these done. So I have a really interesting question on the chat. Can you comment? And this has come from Munir Pir Mamhad. Can you comment on survivor issues, patients developing long-term problems because of adverse effects such as peripheral neuropathy? There is, of course, a big focus on efficacy, but perhaps less so on the long-term adverse effects. And that is an absolutely key, important question. We do know of these problems with cancer survivorship. What do you have to say about that, Shairoz?
So yeah, you're absolutely right. Yes, I think we don't focus enough on long-term side effects of treatment, and a lot of treatments that we give, for example, in breast cancer, we know that it causes what's called peripheral neuropathy, where there's numbness and pins and needles in the hands and feet that can lead to long-term disability. And I think it's really important that we as the government also says rightly in its NHS 10-year plan, that we should be looking at what the long-term effects of cancer are. And I think we're guilty of not focusing too much on the side effects of treatment and the long-term effects of treatment. And I think the key is prevention, really, is I particularly, every time I see a patient on treatment, I proactively ask about that, because it may be not obvious to a patient, for example, but it may be something that we need to make sure that we're proactively asking patients, so that the emphasis really on prevention rather than treatment. So it is important that we need to focus more on long-term side effects of treatment. And peripheral neuropathy is one aspect. We need to look at heart disease. We know that some treatments like radiotherapy, for example, can increase the risk of heart disease. So we need to look at modifiable risk factors. So on one hand, we want to improve long-term outcomes of treatment, but on the other hand, we want to look at modifiable risk factors such that we can improve the long-term side effects of treatment from radiotherapy, for example, by looking at, let's say, cholesterol, high blood pressure, and other risk factors that might increase the risk of these comorbidities. So absolutely right. I mean, I think we don't focus enough, and there should be a greater drive towards making sure that we are focusing on the long-term effects of cancer treatments.
And of course, you can always contact your Macmillan nurse specialist and your Macmillan cancer centres for support on these adverse effects. Do speak to your GPs, because there is GPs who are out there who are aware of these side effects, and there may be places you may be referred into for more support and management of these long-term effects. I'm just aware of time. We have a few minutes left. I'm just going to ask about another question from Mo. Does long-term use of omeprazole lead to cancer? So that's a generalized question. Shairoz, I'm going to give you a minute to answer that.
Okay. So there isn't a direct link, as far as I'm aware, about omeprazole leading to cancer. We know that because of suppression of gastric acid, they potentially, could be other sort of side effects, but there isn't a direct correlation, as far as I'm aware, of omeprazole causing cancer. Particularly, I think the cancer that I'd be worried about is something like gastric cancer, for example, but I'm not aware of a direct correlation.
And of course, we know that omeprazole, like Shairoz said, that it sort of dampens down the side effects of excess acid. So ideally, you should be using your lowest dose of omeprazole that has been guided, and if possible, coming off it if you don't need the treatment anymore. But please discuss this with your GP, because it would depend on why you are on short-term or long-term omeprazole. But the key aspect is if you notice any new symptoms, any change in bowel habit, any increased acidity, that you contact your GP. So we've got just under a minute to go on the remaining recording time. I just want to just finally make a comment about COVID-19 and how it has had an impact on patients accessing services. It is really, really vital that you do visit your GP and get some help. Thank you very much, Shairoz.